Welcome to the American College of Surgeons Bulletin Brief from the front line, Surgeons' Voices. It's with great pleasure that I introduce our guest today, Professor JE Tuttle. Professor Tuttle is chair of the Department of Surgery at East Carolina University and surgeon-in-chief at Vidant Medical Center in Greenville, North Carolina. Welcome, Dr. Tuttle.
Thank you for having me.
Thanks for being with us. During the month of May, we recognize women in healthcare. And as such, we wanted to feature you as a leader, as a woman leader in healthcare, leading a department and leading medical students, residents, and faculty. So perhaps we could start if you tell us a little bit about yourself, what you do, and how you came up through the ranks.
I am currently the Walter Porres Endowed Chair of Surgery at East Carolina University. I am a native North Carolinian. I grew up in a really small town in the western part of the state. I was very fortunate to attend Wake Forest University as an undergraduate and stayed on at the Bowman Gray School of Medicine, which should tell you how old I am because now it's the Wake Forest University School of Medicine on the Bowman Gray campus. I had a little bit of a journeyman career in the beginning after in my surgical training. I ended up in Boston at the New England Deaconess Hospital and finished there in 1995 under the auspices of Dr. Glenn Steele, who later went on to run the Geisinger health system. I came back to North Carolina and spent a year at University of North Carolina in Chapel Hill with George Sheldon doing a critical care year. And then I went to Duke as an abdominal transplant fellow and stayed on as faculty there for about 13 and a half years. Went to St. Louis University. I had the opportunity to redesign a transplant center. I had been a health and human services consultant for the Organ Transplant and Donation Collaborative, which was a quality improvement project to redesign the donation and transplant programs across the country. And I had a great opportunity to go out and put those best practices in place at St. Louis University, and had the opportunity to come back home to be chairman here at East Carolina. So here I am.
Well, congratulations. That's quite an impressive pedigree that you've got indeed. So as you were coming up through your training, perhaps even pre-med, medical school, residency, all the various posts you've held with critical care and transplant, did you have women mentors? And if so, what sort of proportion did they represent from your overall group of mentors?
When I was at Wake Forest in the 80s, there was only one woman surgical attending, and she was a pediatric surgeon. And she didn't stay long. She stayed for a couple of years and then left. My mentors through medical school were men. In fact, my longest serving mentor, Dr. Jesse Meredith, Wayne Meredith's father, who was my medical school advisor, he was my medical school advisor, just died recently. And the old dad and I had been friends for almost 40 years. So he was my mentor in the beginning and was my sounding board throughout my career. When I went to Boston was the first time I really saw women faculty, to be honest with you. And Dr. Steele had decided, I think he and Dr. Bothy had decided that the way to distinguish the program at the Deaconess was to promote women. And we were almost 50% women when I went there. And Dixie Mills, Susan Porres, and lots of other people were really pivotal when I was a resident. However, Roger Jenkins and other people were very helpful in promoting my career. As I've gotten older, certainly I could not have done what I've done to the point without Margaret Dunn and Julie Freischlag and the Association of Women Surgeons, which I was president of, I think, in 2011, but you'll have to double check me. And it's been, it's not male or woman, it's not male or female. I think it is just people who are interested in promoting you and supporting you and putting you out there. So I've had the benefit of having lots of people It takes a village to build a chairman.
Absolutely true. But now that you are chair, do you find that there's any difference in the sort of composition of who comes to you to be their main mentor or not?
I've been very, certainly we have a different surgical department than certainly probably you and I grew up in. My door is open. I am very, I'm not a micromanager. I allow my division chiefs to run their divisions. They are the experts in that clinical arena, but I have expectations of them as well as other sort of senior faculty to have their doors open. Certainly we assign residents, mentors when they arrive, interns, different levels of mentors, depending on what their interests are. My job is to make sure my division chiefs do well and keep an eye on that. And if there's a certain faculty member, for example, Dr. Rebecca Snyder, Dr. Altieri, we published, I think in the Annals, an article recently about microaggressions. We have a group that sort of works together. We have an outcome research group. So I have my fingers in lots of mentor relationships at this point, but that's what our job is at this point. If our faculty does well, then we do well. It's not about us anymore.
Absolutely true. Spoken with words of wisdom indeed. So tell us a little, you've mentioned your department a couple of times, and I'd like people to understand the environment in which you're working.
So we are a 1,000-bed hospital in the eastern part of North Carolina. We are 45 minutes from I-95, which puts us in the middle of a 29-county region, which contains 10 of the poorest counties in the United States. We have one of the highest incidences of metabolic syndrome, obesity, hypertension, cardiac disease. We also have the 5th highest incidence of renal failure in the country in this 29-county region. 2 counties beyond us, the median income for a family of 4 is $15,000. We do not have Medicaid expansion in North Carolina, and this is the anchor medical center for a bunch of critical access hospitals from here to the coast, including the Outer Banks Hospital. So we total have about 1,600 beds within the catchment area and 20 clinical sites. So we take care of the people that are here. That's our job. Our mission is to take care of the patients of Eastern North Carolina, promote health and wellness. We run 6 helicopters. We do about 4,000 trauma admissions a year. Depending on the year, we have either the busiest or the second busiest kidney transplant program in the state. And we also have a large pancreas program. No liver program yet. Maybe someday.
Wish you success on that one. Given the environment in which you're working, 1,000-bed hospital, serving all of these people, it sounds like you've got some significant challenges. And undoubtedly, you've developed expertise in disparities in healthcare delivery, given that environment. Could you share some of your experiences with us?
Sure. I think that from a surgical standpoint, I think that I know the college is focused on promoting rural surgery and rural surgery careers, and it's sort of a catch-22. Hospitals need surgeons to be sustainable, but they don't always have a lot of volume for those patients. They don't always have a lot of volume for those surgeons. And so how do you create a model where there's enough business for 2.5 surgeons, but nobody wants to be on every other night call anymore? So we are trying to figure that out. Certainly locums are an option, and we use way too many of them. But the question is whether or not we can create almost a pool of circuit riders to dedicate their time at different facilities, because we can tell when one of our critical access hospitals, their surgeon goes on vacation. We helicopter lots of things in that don't necessarily need to be here. And poor people don't travel. We did that paper years ago. You know, I think that you'd like to keep patients in the communities from which they come. It's more patient-centered. It makes the family able to visit. But it also prevents waste in the system. You don't need to helicopter people here for surgeries that can be performed at their local hospitals. So we are trying to figure this out. Sometimes we're successful and sometimes we're not. I think one of the things that we've done that has been very successful is Daniel Walsh and a group of governors from the college asked for help to reverse one of the CMS rules where you could only have so many residents at rural hospitals and that would determine their cap in perpetuity. So we've gotten rid of that, which allows us to put residents out in some of these rural training areas. That in and of itself has its challenges, but I think if you show learners the opportunity to do something really cool, there is a certain cadre of learners that will go and do that as a living. So we're trying to promote that from within the residency program. We're also trying to push our medical students out there. The medical school here is very unique. It was placed here in the late 1970s after a battle at the legislature. And the reason that the medical school was placed here by the state was because number one, more than half the Medicaid budget at the time was spent on 29 counties. And it was also placed here to promote recruitment of underrepresented minorities in healthcare and to retain North Carolina residents as practitioners in family medicine and primary care, which surgery counts. And we've been very successful at that. In fact, we've placed almost more than 50%, I think, of our primary care trainees into the state. So it's been a good return on investment for the state.
Sounds like a great return on investment for the state. I couldn't possibly chat with somebody in 2021 without discussing COVID-19. I'd be remiss. In the population in which you're serving, there's already enough baseline challenges. But what's happened with things like screening and access during COVID-19 in East Carolina?
We have had, it was the perfect storm. We had a vacancy in our chair of pathology, and we were able to recruit and retain Jay Fallon, who was a pathologist and a lab director at Columbia Presbyterian, and he moved down to the eastern part of North Carolina as his next step. And he turned out to be an expert in molecular testing. So East Carolina was able to, in the beginning of the pandemic, we were able to stand up at least 3 different types of tests to screen our pre-op patients, to screen our patients coming in the emergency department. And it has turned into a juggernaut. So in lots of different ways, we were better prepared and responded more aggressively than some of our sister institutions in the state. Because our population density is not as it is in the urban areas, the number of cases that we had were not out of control. We were able to sort of contain the cases as you would. I think we responded as everybody did. And we were fortunate that we were not completely overwhelmed. We were overwhelmed to somewhat, but not completely overwhelmed with COVID.
Well, that's great. That's serendipity. But
absolutely.
Yeah, serendipity. Before we wrap up, any additional comments you'd like to make and share with us? Does the chair, by the way, the Pori's chair, require that you're able to do those cartoon drawings and things?
No, but Dr. Pori's, never sit next to him in a conference, because if you're not careful, you'll end up in a cartoon. So that's my word of the wise for Walter. No, it's great to have him here. We are so fortunate to have him still here. He comes in every day but Fridays. During the pandemic, I had to put him on house arrest, and he did not want to stay home before the vaccine was available. And I said, Walter, I'm not going to be the chairman that gives your eulogy. And that kept him home. So
Good strategy. Good strategy. Well, we're glad you're with us, and we're glad he's still drunk.
Yeah, me too. But he's a pleasure to have here, and we are doing the Lord's work here. We really are. I worked at St. Louis University, which was a Jesuit hospital, and I'm not Catholic, but we are taking care of God's people down here, and we do a really good job. We're not very good about blowing our own horn, but we do a great job if you look at our outcomes. And I'm very proud of my faculty, very proud of my resident training program, and we finish a high quality product.
Well, congratulations. Thanks for your time. Thanks for insights. Looking forward to seeing you in person next time.
Yes, sir. Appreciate the opportunity. Thank you so much.